Good afternoon. Our last session for the day will be a panel presentation on sexual function in cancer. Our panelists are Dr. Stacy Tesler-Lindau, Jenna Soft, and Sakith Vintapalli. I am going to introduce all three speakers and then they will give their panel discussion presentation. We will then open the discussion up for questions and I will serve as your moderator. Dr. Stacy Lindau is a practicing gynecologist with expertise in preservation and recovery of female sexual function during and after cancer. She is founding chairperson of the Scientific Network on Female Sexual Health and Cancer and founding director of the University of Chicago Program in Integrative Sexual Medicine for women and girls with cancer. To accelerate knowledge dissemination and expand reach to women without access to specialized care, Dr. Lindau founded Women Lab, a web-based platform co-designed with women affected by cancer to preserve and recover sexual function after cancer. Dr. Lindau leads the Bionic Breast Project with neuroscientist Slayman Besmani and interdisciplinary efforts supported by the National Cancer Institute to restore breast function after mastectomy. Our second panelist, Dr. Jenna Soft. She earned her medical degree from Vanderbilt University School of Medicine. She then completed a pediatric residency and pediatric hematology oncology fellowship at Children's Hospital Colorado and University of Colorado, where she also earned a Master of Science in Clinical Science degree. She's an assistant professor in the Department of Pediatrics, Division of Hem-Onc, where she specializes in solid tumors and cancer survivorship, as well as serves on the Fertility Preservation and Reproductive Late Effects team. Her clinical research aims to improve quality of life in pediatric cancer survivors with a focus on improving screening and diagnosis of sexual health and function among adolescent and young adult survivors. Dr. Sof is an active member of the Sexual Health Task Force of the Children's Oncology Group and also is currently contributing to the update of endocrine sexual health long-term follow-up guidelines through Children's Oncology Group. While early in her career, she has authored 16 papers, including several focusing on sexual health and function in pediatric cancer survivors. She is a recipient of local awards and foundation grants that support her work. Dr. Sakith Vintapalli is our final panelist. Dr. Vintapalli is an associate professor, Karen M. Jennison Endowed Chair in GYN Oncology and director of the Division of GYN Oncology at the University of Colorado School of Medicine. He formerly served as vice chair for clinical affairs quality improvement in the Department of OBGYN and director of the fellowship program in gynecologic oncology. He received his undergraduate degree from the Johns Hopkins University and his medical degree from the University of Texas at Houston. After residency at Baylor College of Medicine, Dr. Vintapalli completed a fellowship in GYN oncology and advanced pelvic surgery at Washington University in St. Louis. Dr. Vintapalli is a leading national and international expert in women's care and has lectured all over the world on surgical expertise and molecular mechanisms of cancer. He has authored over 60 clinical papers and led multiple collaborative research studies focused on improving post-op surgical outcomes and novel therapies for the treatment of ovarian and uterine cancer. With over $3 million in independent research funding, Dr. Vintapalli has led the NRG Collaborative Research Consortium at the University of Colorado Cancer Center for nearly 4 years. Dr. Vintapalli has authored a New York Times reviewed book and multiple editorials in Forbes on sexual dysfunction in cancer patients. He serves on multiple national committees, including the chair of legislative affairs for the Society of Gynecologic Oncology, as well as serving on the executive committee of the Western Association of GYN Oncology. It is my pleasure to turn this over to our esteemed speakers.
Hello, I'd like to provide an introduction first to sexual function and cancer, starting with just what we are talking about with this. First, I have no conflicts of interest to disclose. We are going to do an overview of sexual function, review barriers to care, highlight key communication tactics for taking a sexual function history, and discuss types of sexual function concerns, including both male and female challenges. So first, sexual function after cancer. Sexual function concerns can occur in anywhere between 20 and 50% of childhood cancer survivors, and blocking out, but up to 80, 90% of adult cancer survivors, depending on the cancer type. Types of concerns include diminished sexual desire, diminished sexual pleasure, failure of genital response, including challenges with erection or vaginal dryness, decrease in orgasm intensity or frequency, and premature retrograde ejaculation, dyspareunia, and changes in body image or sexual self-esteem. This is a diagram that gives an overview of the pathophysiology for sexual dysfunction related to cancer survivorship. There are many potential reasons for challenges related to sexual function in cancer survivors. I will highlight that this diagram was made for childhood cancer survivors, so we'll omit things a little bit like endocrine therapy, which would also be included in such a diagram if it were for the whole population. But for example, we have alkylating chemotherapies affecting reproductive sex hormones. This is where endocrine therapies or hormone therapies would also go in, potentially related to effects on hormone function and premature ovarian failure, as well as hypogonadism. Notably, though, other studies suggest that any chemotherapy might be a risk factor. Similarly, radiation to the pelvis not only causes commonly recognized late effects, such as risks to fertility and hormone production, but can also be associated with concerns that may arise as patients mature in terms of pediatric patients or throughout their adult lives, such as erectile dysfunction, vaginal scarring, shortening or dryness, and decreased blood flow. Cranial radiation can affect sex hormone production as well as normal psychosexual development. And central nervous system and spinal, retroperitoneal, and pelvic surgeries can also affect sexual health and function through nerve disruption, changes in anatomy, and in the case of a CNS surgery, normal development, especially for pediatric patients. Just as these effects can be detrimental to physical health and reproductive ability, they can have profound impacts on mental health and quality of life. So despite all of the biologic factors I previously mentioned, they haven't been consistently predictive of sexual dysfunction across studies, likely due to these other psychosocial factors at play. Experiencing cancer, even in the absence of specific risk factors, can disrupt normal development in younger patients and can disrupt where somebody is in their usual development through adulthood in psychosexual ways. Childhood cancers and survivors in particular also experience challenges related to forming romantic relationships, but then all survivors are really potentially may have this challenge as well as body image and other related concerns that may in turn affect sexual function. Unfortunately, despite the high rates of prevalence of sexual function concerns in cancer survivors, there's incredibly poor recognition, with about a quarter of adult survivors reporting wanting help for such a problem. Internists, about 2/3 report rarely or never discussing sexual dysfunction in their cancer survivor patients. And a qualitative study of 22 young adult childhood cancer survivors had all of them reporting unmet sexual health needs. There is an additional study where less than 5% of female adolescent and young adult patients with sexual function concerns received the medical care that they needed for these concerns. Importantly, patients report a desire to speak with their oncologists about sexual and reproductive health, but want their providers to take the lead. There are a lot of barriers when it comes to these communications. On patients' part, they are hesitant to initiate conversations and may have discomfort, but more importantly, they notice provider discomfort, and they have some concerns, especially younger patients, about confidentiality. Oncologists report that they have their own discomfort or they worry about patient discomfort. They also may have a lack of knowledge or experience, resources or referrals, or especially in the case of younger patients, have parents and family present and may not always have those private conversations with their patients. Providers also note that a lack of rapport can be a challenge in touching base on such a sensitive issue, and it may be a low priority or they have limited time. Internists also report lack of knowledge and experience and concerns of patient discomfort. These barriers of note are particularly poignant when considering adolescent and young adult oncology patients and survivors. There are also misperceptions about AYA sexuality in cancer. particularly focusing on this AYA group, but really all may be considered to be too sick and not having sex. And particularly in AYA patients who do not have sexual experience at the time of diagnosis, there's an assumption that there's nothing to rediscuss throughout therapy. They're not going to suddenly become sexually active, when we know this is actually not true. Cancer survivors are less likely to engage in risky health behaviors. That is something that is not true again, so another misperception. And AYA are too young to have sexual function concerns. Again, a misperception. In reality, patients remain sexually active during cancer treatment. And many AYA patients have their sexual debut during cancer treatment. For example, 26% at diagnosis had ever had sex, and 59% on therapy of the same population surveyed later. Adolescent survivors engage in risky behaviors, with 29% not using, or 29%, using birth control or condoms, compared to 44% at diagnosis. So really, they actually became increasingly risky with their sexual behaviors while on therapy. And between 20 and 50% of AYA cancer survivors have sexual function concerns. To address communication barriers, it's important to consider confidentiality. It's establishing an expectation that you will have one-on-one communication with the patient, periodically asking family to step out. This is true, of course, for AYA, but other adult, older adult patients as well, who may come with their spouse, for example. Discomfort, addressing discomfort by normalizing ongoing communication that is direct and initiated by the healthcare provider. First, set the stage, explain the reasons for discussing sexual health and function, and establish rapport by following up periodically, which will normalize the conversation and allow it to be tailored more to the patient. Address your own lack of knowledge. Patients note that they don't expect their providers to be an expert. You need to be an expert in how, as an oncologist, to ask these questions, and then be prepared to establish connections with endocrinologists, gynecologists, urologists, sex therapists, and more. And then to address low priority, we simply need to make this a priority. With 20 to 80% of cancer survivors experiencing sexual function concerns, we really need to address this. And then limited time. By engaging in this conversation regularly, each time should be less time. Each visit that you're discussing this should be less time intensive, as you will have that rapport and be able to tailor the conversation to the patient. And also, another opportunity is to consider the use of a screening questionnaire, which may address your own lack of knowledge and comfort with asking some very specific and personal questions about sexual function, and also may be able to get to the root of some problems. Basics, introducing the topic, as I mentioned before, asking permission to discuss this, and then starting with the basics. Are they sexually active? What is their gender identity? What's their sexual orientation? And then beyond that, partners with men, women, or both is always important to ask, even if you know their sexual orientation ahead of time. Current and historical sexual practices, so finding out what their sex history is, as well as what's going on right now with them, and then asking specific questions about sexual function. So starting generally, but it's really important to ask specific concerns, such as about erection or ejaculation or pain with sex, discomfort, et cetera, and get really into it, because I think patients may not realize that they have a concern that could be related to their cancer or treatment. And again, considering the use of a screening tool. Apologize for that. Now just briefly going into male sexual function after cancer. Concerns that we see, I briefly mentioned before. Ejaculatory dysfunction is the most consistently reported concern, whether that be dry or retrograde. Difficulty with orgasm, erectile disorder, decreased desire or interest, and decreased satisfaction or enjoyment. Approaches will depend on what the concern is. For example, with ejaculation problems, considering Sudafed or electroejaculation for fertility purposes, obviously not for like sexual self-image as a way to address it. Sexual response, talking about phosphodiesterase type 5 inhibitors, vacuum devices, or other procedures and injections, as well as psychotherapy and counseling or regular stimulation. Hypogonadism, you will treat with hormone replacement. Satisfaction with counseling or psychotherapy, and particularly involving the couple, the partner, if there is one. hot flashes or sweats can be treated with medications and body image via psychotherapy as the primary. And so these are really the basic treatments. Of course, it's going to take expertise, but the important thing to know is that there are ways to address these concerns, and they may require more than one approach because these often are multimodal in their nature. I will now switch to sharing Dr. Lindau's slides.
Thank you so much for driving the slides. I really appreciate that, and for your great talk. I'm honored to be invited to be among this terrific panel and all of you for this session today. I think I was asked to stick to 10 minutes, so I have a brief presentation here, but of course I'm very happy to ask questions when the time comes. Next slide, please. I never had disclosures aside from my research funding, but as one gets older, there's more opportunity for these. So I'll just give you a moment to review. And next slide, please. So I hope with this brief presentation, you'll be able to define female sexual function. I'm an obstetrician gynecologist, and so I focus on people who feel that a gynecologic approach will be appropriate for their sexual function concerns. I want to explain vaginismus, which I think is a nice complement to the talk you just heard, more of a musculoskeletal understanding of common sexual function problems. And I hope that from this talk and the whole panel experience, you'll be able to incorporate into practice an understanding of the effects of dyspareunia on other aspects of sexual function. Next slide. So we look to the DSM-5 for definitions of sexual dysfunction. And of course, in clinical medical practice, one does not need to meet the DSM-5 threshold in order to have a billable or a medically appropriate diagnosis for sexual function concerns. But these definitions are important in psychiatry practice and also definitions that are applied in drug and other intervention development. So worthwhile to understand. There are three main disorders that we see in the cancer patient population among women: genital pelvic pain and penetration disorders, and this can include penetration difficulty, anxiety or fear about penetration. Interest and arousal disorders, these two types of disorders used to be treated as two separate classes of sexual function disorders. They've been combined in the most recent definitions, and these include reduced interest in sex, reduced excitement, and difficulty with genital or decreased genital sensation. Some patients will say, I don't feel anything down there anymore. And typically it's not because there's been a nerve severed or destroyed. Oftentimes it's because the arousal physiology isn't intact. And orgasm disorders, and these are the least common disorders, especially primary orgasm disorders, but these include complaints of delay, absent, infrequent, or decreased intensity. And decreased intensity of those, I would say, is the most common of the orgasm disorders. To meet the DSM-5 criteria, these disorders would persist for 6 months or more and occur 75 to 100% of the time, although the pelvic pain criterion refers to the persistence or recurrence of the condition. These occur with clinically significant distress for the person herself. And in the past, historically, as a woman could be considered having a sexual dysfunction if the problem were distressing to her partner, for example. So I think this is an improvement in the definition. And it occurs in this definition as independent of relationship distress, other medical conditions, and non-sexual mental disorders. Now, in the cancer patient population, regardless of the patient age, it's almost impossible to meet this criterion because, of course, most of our patients have iatrogenic loss of sexual function. And most of them also, I shouldn't say most, but many experience relationship distress, and anxiety, depression, of course, are very common in our cancer patient populations. Next slide. So common primary diagnoses that I see in my practice, and I've been exclusively focused on helping women with cancer and other complex illnesses recover their sexual function after cancer treatment. The most common diagnosis is dyspareunia or painful sex. This commonly occurs with a condition called vaginismus, or a tightening of the muscle around the introitus, around the opening to the vagina, and typically occurs in the setting of what's called high tone pelvic floor muscle dysfunction. anyone who's gynecology trained would have had more exposure to low tone or laxity, pelvic floor dysfunction that involves urinary incontinence, maybe stool incontinence, and laxity or looseness of the pelvic floor muscles. But in this patient population, we see some of those same symptoms, but the mechanism isn't that the pelvic floor muscles are loose, it's that they're very, very tight, including that introital muscle. We also see very commonly, especially in patients who've had anti-hormone therapy, as in our estrogen receptor positive breast cancer patients, vulvovaginal dryness, inflammation, and contact irritant dermatitis is a very common problem. And it's because women are using products to clean in the genital area that they may have always used, but now the epithelium is so thin that they're more vulnerable to these irritants. And of course, vulvovaginal atrophy. Loss of or diminished libido is very common, oftentimes as a consequence of dyspareunia. And if we can correct the dyspareunia, we can also address libido in part, and acquired difficulty with arousal and orgasm. So most of our patients, especially the patients who have had sex before, will say that they had sexual function, including orgasm function, before their cancer treatment. Next slide. So here you see a picture of the female anatomy. Imagine a patient in a dorsal lithotomy position, and we're looking straight on at the vulva as we do during a gynecologic exam. The muscle groups here are ones that are difficult to dissect in anatomy in medical school, and so many of us lack familiarity. Even in my own gynecology training, it took a long time to really gain mastery and understanding of these muscles. I want to point first to the external sphincter ani muscle, because we're all familiar with that, regardless of our gender, our sexual orientation. We all know our anal sphincter muscle, and we use it on a regular basis. This muscle, by definition, as a sphincter muscle at rest, is typically closed at rest. In order for the muscle to open, we need to do something. We feel a sensation, need to defecate, and then there's a bearing down motion or a Valsalva motion that will overcome the pressure of the muscle at rest in order to achieve the function. You might notice now, looking at this picture, that there's similarly a circumferential muscle around the opening to the vaginal introitus, and this is called the bulbocavernosus muscle. It also is a sphincter muscle, and even in the older anatomy textbooks, it's referred to as the sphincter vaginae muscle. At rest, it's slightly closed. When there's been pain, when there's been trauma, physical or psychological trauma that involves the sexual organs directly, or that causes worry for a person about whether or not they'll be able to have penetrative sex, this muscle tends to tighten more. And it can even produce a sensation of a wall or a blockage that a person who's had cancer before might reasonably worry is a cancer recurrence. Now, I've never seen that before, but this is the kind of fear that patients who experience this kind of sexual dysfunction, dyspareunia with vaginismus, they bring, and they want to ask, but they're afraid to, for the reasons that Dr. Jenna just mentioned. So if you don't mind, next slide, just click the button there, and you'll hear, these are the words that patients say when they have this problem, this vaginismus problem. They'll say, and I use she and he here, that recognizing that there are all kinds of partnerships and genders, but in my practice, most of my patients identify as she, and most of them identify with a he partner. It feels like he's hitting a wall. I feel like I'm scarred shut. It feel like a virgin again. And if you've had radiation to this body part, if you've had surgery to this body part, and like I said, if you've had cancer, there's reason to imagine that these are the causes of your sexual dysfunction, when the problem really is a very tight muscle that can be corrected with pelvic floor physical therapy and self-dilation. And that can restore not only penetration, but by releasing the tightness in the muscles can make it easier for blood to flow to these important organs and to restore sensation. So oftentimes that pain, the tightness, the difficulty with penetration problem, when corrected, will also improve sensation, arousal, and orgasm. Next slide. So this is what the dyspareunia cycle looks like for patients who are initiating sex for the first time after cancer treatment, who are resuming sex. There may be a slight feeling of fear or anticipation, uncertainty about how it's all going to work. But there's desire, and there's arousal, and there's attempt at sex, and then pain it occurs. Next slide. And when pain occurs, what happens? Fear goes up. And when fear goes up, desire goes down and becomes harder to become aroused. Those muscles become tighter as a preventive mechanism subconsciously to prevent against painful penetration. And next slide, the cycle continues. This is a very, very common presentation in women with cancer. And the good news is it's very correctable. Even just explaining what I've just explained to you to a person who's had these symptoms itself can be therapeutic. Next slide. And so when these problems occur, we see loss of desire and click again, and loss of arousal and click again, and loss of orgasm, like I've said. Next slide. So we've created a resource to serve the needs of people, patients, partners, and clinicians. And we've created materials that fill gaps in the excellent materials we find already out there in the world. So we're not trying to duplicate anything. But for example, we've created a document to help people identify the right pelvic floor physical therapist for their concerns. Many pelvic floor physical therapists are well trained in urinary and fecal incontinence, but are less well trained in addressing sexual function concerns. So this document helps ask the right questions and says what the right answer should be if you found the right therapist. We have a video on what is sex therapy, because oftentimes doctors don't know and patients and their partners don't know. We have tools that can be used in the clinic or by patients themselves to understand about moisturizers, which can be very helpful to address these problems, and lubricants. We also have information about self-dilation. What is dilation? How do you do it? And this is all just to normalize these kinds of interventions for people and to help clinicians get up to speed if frontline guidance is needed in the oncology context. There are many more resources at womanlab.org. That's where these tools are coming from. And I hope that you'll see that as a resource. Next slide. Thank you so much, and I'll look forward to the discussion following the panel.
Dr. Guntapalli, did you have anything you wanted to particularly state?
So first of all, that was really, really outstanding. Thank you to Dr. Stopfi and Dr. Lindau for kind of setting the stage for what I think is an incredibly important discussion. I just wanted to add, I think that sexual dysfunction in cancer patients is probably the single most undertreated diagnosis or single most unrepresented survivorship issue that patients face. And, as a G1 oncologist, I must admit, I did not go into my career thinking that I'd become an expert on sexual dysfunction in cancer, simply because it's not exactly the first thing that you're ever taught in your training, but it's so incredibly important. I was just going to briefly share kind of what our approach and what my approach is in clinic. I only treat female patients that have either ovarian, endometrial, cervical cancer. So they get a lot of different modalities of therapy, including surgery, including radiation, including chemotherapy. And what I tell the patients, it's kind of like a three-pronged approach. The first is communication. And I know that's very kind of overused, and we talked about how important communication is, but it really is the most important part of the treatment of sexual dysfunction. And I think it's important because a lot of patients come into their cancer treatment and their diagnosis with the expectation that everything is going to be the same. And what I tell patients is you may have to have a little bit of a reset on your expectations because things are different after you have a major surgery in terms of just your body image, which seems to be among the biggest things that changes after a breast cancer or ovarian cancer diagnosis. So kind of communicating with your partner about what expectations are, and really, what is your expectation from sexual encounter after a diagnosis of cancer? Simply because when you're engaged in sexual activity, I think we're very conditioned in our country to have this kind of idea of foreplay, orgasm, resolution, and that is what sex is. And sexual functioning for women is so much more than that. It's not just this very methodical way in which we're all conditioned to look at sex. And I tell patients it's really important to talk to your partner about what your expectations are and what is it that you want to get out of your sexual experience. Now, that's not something that I think comes very naturally because sexual encounters tend to happen very spontaneously. But I think that at the beginning, in the middle, at the end of treatment, I always encourage patients to do that. The other two interventions that I think that are so incredibly important with regards to sexual functioning after cancer Number two, other than communication, is positioning, because I think that when patients have a diagnosis of cancer, with the anatomical changes that come with surgery, with the fatigue that comes with chemotherapy, it's really important to tell patients to think about positioning when they're having sex. And then lastly, and Dr. Lindau kind of talked about this, I think this is probably the single biggest intervention that patients could use for sex after diagnosis and treatment of cancer, is the use of a good lubricant. We don't ever talk about that. And I always talk about that now, that a very, very important part of sexual functioning for women after treatment of cancer is the use of a water-soluble good lubricant. And that, I think, has solved, at least in my practice, 30 to 40% of sexual functioning problems, particularly in postmenopausal women that have a lot of vaginal dryness, women that have hysterectomies and lose that upper part of the vagina or have a scarred vaginal cuff, particularly patients that have received radiation. So I think that those are some of the things that you see, particularly in women with cancer diagnoses, that kind of at least are the start of the discussion of sexual functioning. And then lastly, I always encourage patients to seek out a formal sexual health therapist. I'm a very, very big advocate of that. And I think that's incredibly important as part of this kind of global approach to sexual functioning in women with cancer.
Excellent, thank you. There are some questions here. So the first question is there a sexual function screening tool or questionnaire that you recommend?
From an adolescent and young adult perspective, so many of these screening tools are validated down to 18, but not below, with none below age 18. I have trialed using in a qualitative study the PROMISE tools. Specifically, they have many different tools, but there's one called the BRIEF that's sort of a better as a screening than a diagnostic tool. And that one, there's a male and female version. So if you have patients that are both sexes, can be helpful. I will highlight that it doesn't get at distress, and many of them don't get at distress. And I think Dr. Lindau mentioned that that's an important piece of the sexual function really definition. In terms of depending on who your patients are, there are more specific female or male directed ones, such as the FSFI for females, or the erectile dysfunction. I'm just blanking out on the full term for the male one, that I have not personally used because they're not validated at that younger age. But I will see if Dr. Lindau or Gutapalli have anything to add.
Sure, I'll put in a plug also for the PROMISE Sex FS. I think it's a very, it's a well-developed and validated tool. And I would say though, in my clinical practice, it's less useful for clinical purposes because an in-depth history is necessary anyhow. It's much more useful as an adjunct for systematically collecting information that could be used for research purposes. The FSFI, the Female Sexual Function Index, obviously has been widely used. It's been favored in pharmaceutical trials. It has been well studied, and I think has its usefulness as a tool. There is a female sexual distress scale, which I do use as a measuring stick as part of my routine clinical care with patients. It's I think maybe 10 or 12 item checklist. And what I like about it is it's very useful to quantify the level of distress over time. And patients can understand it. You can add up the numbers and you can show them how things are changing over time, which I think can be very reassuring. Oftentimes distress comes down before function returns if you've developed a good therapeutic alliance with the patient, because they feel they're no longer alone. They feel validated in their concerns. They've gained an understanding that these concerns are not their fault. They're not in their head. They're actually iatrogenic in many ways. And just that validation can bring the distress down, which I think helps in the success of the other therapies. And then last, I'll say Catherine Flynn, fantastic social scientist in the field, have worked with Kevin Weinfurt at Duke on the Sex FS for PROMISE. Catherine also led a paper published in Journal of General Internal Medicine on a single item screener that works for males and females to assess for sexual function. And that's a really practical tool for the oncology practice. in our clinics, in our GYN oncology clinics, we just added one question. Do you have any sexual function concerns to the GYN section of the intake form of the review of systems? And even that one question is useful to identify people who need attention or need referral.
Everything, I agree with everything everybody said. We use a lot of the FSFI simply because we're numbers people, and I think it's just very easy for us. And we've done some longitudinal studies on kind of how that difference changes, kind of where it starts, where it goes down in the middle of treatment, and then up again. But that would be the one. Intimate bond measure is a great tool for kind of the solidity of a intimate relationship as well. We don't use that as much. We use more in the FSFI.
Perfect, thank you. Another question. For our patients who are on oral chemotherapy, namely, I think it's mercaptopurine and methotrexate for an extended amount of time, do we know if these are showing up in the bodily fluid? And thus, should we teach about barrier needs during intercourse? And what else do you suggest? Is this for this panel?
Yeah, anytime a patient is actively receiving chemotherapy or chemotherapy that wouldn't have cleared from their body yet should be using a barrier method to protect their partner. I think there was a second part to that question that maybe I've missed. What else do we suggest?
Yes, what else do you suggest?
Mm-hmm. We generally recommend 24 hours at least after infusion of chemotherapy. There's actually some data that's actually been published on this in some of the, not all chemotherapies, but some of the bigger ones like platinums, taxanes, that it is excreted in bodily fluid and vaginal fluid and semen 24 to 48 hours. So that's generally what we tell patients to use, and to use if they're going to have relations in that time, to use a barrier method.
Excellent.
I would love to.
Go ahead, Dr.
Could I add one interesting thing here, since we're talking about treatment, but it's also the case that tobacco smokers, we find metabolites of tobacco and toxins associated with that in the male semen, concentrates there, and sometimes levels can be even higher than blood levels. We've long known of there being a synergistic relationship between tobacco smoking, HPV, and cervical cancer. And I tried for many years actually to design a study that would help us know whether that's partner exposure to tobacco toxins through sexual intercourse could be more of a direct mechanism through which we see that synergy. So when we think about toxins that might be problematic, let's also think about how to counsel patients whose partners are smokers to minimize exposure. And also, I once had a patient whose partner was using very high dose methotrexate for rheumatoid arthritis. My patient didn't have cancer, but she was having recurrent vaginitis. Once they started using condoms, the vaginitis problem improved.
Fascinating. All right, two last questions. Any advice on timing of treating sexual dysfunction in female pediatric cancer patients who had pelvic radiation therapy? For instance, timing of pelvic floor rehab, such as prior to becoming sexually active. So the question would be about healing time, and then wanting to make sure that we don't catch that too late, right? And then we start some intervention sooner.
I'll defer to Dr. Linda on the treatment piece, but I think that healing time, we typically think post-radiation, you need around 2 to 3 months to reduce inflammation. I don't know if Dr. Linda feels like that would be the time to wait prior to doing any therapy.
This is an area where I feel like the evidence base is very limited. In younger people, in adolescents, for example, I would say in the art of medicine, I would say the sooner we can introduce the concept of vaginal preservation with patients and their caregivers, parents, the better. Even if they're not going to initiate dilation, self-dilation, or work with a physical therapist, just simply saying one of the things we need to do here is preserve this part of your anatomy, and there are ways we can do that would be extremely important. And with younger girls or babies where we know this is going to be an issue, talking to parents early about this, I think, is important, because everybody worries about it. They're just afraid. They're afraid to ask. In terms of older, adult patients who are sexually active, I would say the same. The sooner we can introduce the concept of vaginal preservation, the risk of vaginal scarring and stenosis and how those can be prevented with self-dilation and also with the help of a physical therapist, the better. I would hypothesize that the earlier we talk to people, the more likely they are to engage in those activities. Those of us who practice in this field have many examples of patients who had radiation. Somebody did give them a dilator or mention this was important, but they either couldn't cope with that information at that time, or it wasn't really discussed with them in a manner that they understood that if they didn't do it, they would lose their function or the vagina could scar shut. And so we see those patients with really advanced scarring that simply cannot, no matter how much physical therapy or self-dilation, can't be addressed. It sometimes even requires vaginal reconstruction. Our radiation oncologists with our pelvic floor radiation patients do introduce the dilator concept early. They typically give people the single white nylon, rigid, hard dilator. The radiation oncologists seem to prefer that one. And then we'll oftentimes refer them to us. And we're typically seeing them as soon as the local inflammatory process has healed.
Excellent. Thank you so much. So thank you for this very necessary discussion. For the conference attendees, there will be a breakout session on this topic tomorrow at noon. Dr. Jenna Soft is going to lead that session with one of the sexual medicine providers here at the University of Colorado. Thank you for joining us for day one of the conference. Again, please select the question mark in the upper right corner in the virtual space for any concerns or assistance with the conference platform. Have a great evening, and we will see you at 8 a.m. Mountain Standard Time tomorrow. Take care. Thank you to our presenters.
Thanks so much. Good to see you.